Start. Good evening, everybody, and welcome to this evening's G-EHCO session, which is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. It runs, as you know, every second Monday at 1800 hours. And so the chat will be open to the questions. And Aslam is going to present today on post-operative recurrence. I'm just going to let him complete his presentation, and then I will be available for questions or make some comments, whatever. So Aslam, if you want to start sharing your slides, and then we can kick off.
Can everybody see?
It's not in presentation mode. You just need to click on slide show.
I'm going to put it now in presentation mode.
Yeah, that's correct. Okay, go for it.
Perfect. Okay, good afternoon, good evening, everyone. I'm Aslam. I'm one of the fellows in gastroenterology at Stellenbosch University and Tygerberg Hospital. Thank you to Prof. Ottermeyer and my team for assisting in presenting this talk. So today I'll be talking about post-op recurrence of Crohn's disease. So the pathophysiology the pathogenesis of post-op recurrence of Crohn's disease centers on the following key factors: a dysregulated immune response to intestinal microflora, genetic predisposition, and environmental conditions. The presence of an ileocolic anastomosis and smoking are the only well-replicated risk factors to date. Paul Rutgeerts did a study many years ago, and he showed that patients that had undergone resection without bowel continuity initially did not have recurrence, but then later they developed recurrence after bowel anastomosis. So this highlighted an important fecal stream as a factor. In the post-operative setting, the microbial flora is altered through loss of the ileocecal valve, altered integrity of the mucosal barrier, and perhaps an imbalance between commensal and pathogenic bacteria. Imidazole antibiotics likely work by altering the gut microbiome. In terms of smoking, there's various theories. Smoking may have immunosuppressive effects influencing cellular and humoral immunity. The vascular changes caused by the components of tobacco smoke, such as oxidizing chemicals, may have prothrombotic effects, which in turn could exacerbate ischemia of the small bowel. Future directions in Crohn's disease relate to prediction of disease outcome and evolution based on an individual's bacterial flora, environmental exposure history, and immune response and genetic makeup. So I've added in a slide on the mesenteric involvement in Crohn's disease because there are some novel surgical approaches to this. Increasing data suggests that the mesentery is involved in Crohn's disease. Mesenteric adipose tissue and alterations in mesenteric lymphatics correlate with disease progression of Crohn's disease. Accumulation of visceral adipose tissue, increased mesenteric lymphatic vessel density in the mesenteric resection region, and the presence of granulomata in the mesenteric lymph nodes are associated with increased rates of post-operative recurrence. Bacterial translocation is common in mesenteric fat and may contribute to the inflammatory response in Crohn's disease. So the natural course of post-op Crohn's disease. So essentially a patient undergoes resection. What to note, the patient is not cured of the disease. Within 1 week, there may be histological recurrence. Within 1 year, endoscopically, there may be evidence. But to note about the natural course, most importantly, is clinical symptoms often remain silent. They occur once tissue damage has already occurred, and this is often too late. 30% of patients by 3 years, 60% by 5 years, and then at 50% of patients by 5 years. To note, this slide was done in 1992, which is essentially the pre-biologic era. The Crohn study highlights very well in our post-biologic era that the cost is now shifting toward medication as opposed to surgery and hospitalizations, which was the norm before. And then also patients are variable in terms of recurrence. Some patients may have recurrence at 1 year, some may have it at 10 years. So predictors of recurrence. So there's patient-related factors as well as disease-related factors. In terms of patient-related factors, tobacco smoking and a female gender. Disease-related factors would be a prior surgery, penetrating and perforating disease, young age, specifically under 30 years old, shorter duration of disease before surgery, that is less than 10 years, the use of steroids, multi-site disease, and a family history. Breaking up these various risk factors, one can risk stratify recurrence. So high risk factors would be a current smoker, a history of perforating or penetrating phenotype, history of perianal phenotype, a history of at least 2 prior surgeries, and then a younger age of less than 30 years old. Moderate risk factors, one could put the patient with a longer segment of diseased bowel at the time of resection that is more than 10 centimeters, and then a shorter time to initial surgery, which is less than 10 years. In the paper which I used to quote these risk factors, they identified low-risk patients as someone without an identifiable risk factor, as mentioned before. In terms of assessing recurrence, we have various modalities, invasive and non-invasive modalities, which I'll go through in the slides to follow. So the gold standard for assessing recurrence of Crohn's disease remains endoscopy. Endoscopically, we have a scoring system described by Paul Rutgeerts, which is called the Rutgeerts endoscopic recurrence score. Essentially, one does endoscopy to the near-terminal ileum. The score is from 0 to 4, with 0 and 1 being defined as remission and 2 to 4 being defined as recurrence. There is a modified Rutgeerts score where I to A essentially is broken up into I to where I2 is broken up into I to A and I to B, with the thought process that I to A will likely not progress to more to higher scores for the Rutgeerts score. However, one needs to note that there was a meta-analysis which was done this year, published in the Journal of Crohn's Colitis, which didn't show any difference in terms of clinical or surgical post-operative recurrence. We will need to do further prospective studies to assess this. I think the most important thing is to describe very well what is seen on your endoscopy, specifically at the anastomosis site. Video capsule endoscopy has sensitivity and specificity for post-op recurrence of 50 to 79% and 94 to 100% respectively. There's always the risk of impaction in strictures. MRE has sort of replaced CT interrography in assessing patients with Crohn's disease. There's a study done by Koliko in IBD in 2010, where conventional endoscopy using the Rutgeerts scoring system was compared to MRE. So the classification of findings was MR0 to MR3, with 3 being the severest of recurrence. And then when compared to Rutgeerts score, there was substantial agreement statistically with a kappa value of 0.67. Then the MR2 and MR3 sensitivity and specificity was 89 and 100% for I3 and I4 disease. In our setting, there is often limited access and cost involved with MRE. Fecal calprotectin, another non-invasive test to assess patients. There's various studies looking at various cutoff values for fecal calprotectin. So I'm going to mention 2 studies in the talk today. The first study had a cutoff value of 50 and a lactoferrin of 77.5, and then increased to 2 times the upper limit of normals with a predicted disease flare, and then both were better than CRP in post-op recurrence prediction and had better sensitivities. Then in the other study, it correlated well with Rutgeerts score and can be utilized to monitor for post-op recurrence and response to treatment. And then it predicts post-op recurrence with greater accuracy than the CRP or the CDAI. In this study, the cutoff level, the optimal cutoff level was 100, and then it had a negative predictive value of 90%. But I think the take-home message with fecal calprotectin is that it will never replace endoscopy. And then also it's not specific only to IBD. Therefore, the rationale when using this test should be as a complementary investigation. I know when I was reading to prepare for this talk, there's in Europe, intestinal ultrasound is being used and combining that with fecal calprotectin in predicting post-op recurrence. So, predicting recurrence. Which patient, when to treat them, and which prophylaxis to use for them essentially. So I'll be going through some landmark studies to help answer these questions. So the POCUS study was a study which included 174 patients post-operatively. Patients were labeled high risk or low risk. High risk if they had more than one of the following factors: smoking, perforating disease, previous resection, and then high-risk patients in this study were received thiopurines or adalimumab. They received the adalimumab if they were thiopurine intolerant, and then the low-risk patients received no treatment at all. The aim of the study was to follow up patients over an 18-month period, with the primary aim being recurrence at 18 months. Patients were randomized into two groups. The active group had colonoscopy to assess for endoscopic recurrence at 6 months. If recurrence was found, then treatment would be altered appropriately. So that means that treatment was escalated dependent on G-EHCO, even if the patient was asymptomatic. So if they were not on any treatment, they were then changed to a thiopurine. If they were on thiopurines, they were changed to adalimumab. And if already on adalimumab, the dosage intervals would be decreased. The standard group in the study did not have colonoscopy at 6 months to assess for recurrence, and then all patients were treated with metronidazole for at least 3 months unless they did not tolerate it. So the result of the study, one can clearly see the active group had less recurrence defined by G-EHCO compared to the standard group, where the active group had 49% compared to 67% recurrence. This study greatly informs our practice of performing endoscopy in patients with post-op recurrence, post-surgery. Then there's been various imidazole antibiotic studies. They were all original placebo-controlled trials. The metronidazole study used 20 milligrams per kilogram per day versus placebo for 3 months. And then the onidazole trial used 500 milligrams per day BD versus placebo for a year. Both trials showed less recurrence of disease compared to placebo, but then also in both trials, stopping antibiotics resulted in recurrence. One really needs to note the very high doses of metronidazole used in these studies, and patients had severe side effects on these antibiotics. There was the low-dose metronidazole versus placebo study done by Glick et al., where 250 milligrams of metronidazole was given 3 times a day for 3 months. The primary outcome was endoscopic recurrence within 12 months, which was defined as greater than or equal to I2. 23% of patients had adverse events. 8% of patients had the medication stopped due to their adverse events. And then there was a prevention of post-operative recurrence. However, there was recurrence again once the medication was stopped. So if one looks at the data of the study, one can clearly see that recurrence was much less in the low-dose metronidazole group compared to the control group. Then one looks at the PREVENT study, which was a randomized trial to compare the ability of infliximab versus placebo to prevent post-operative Crohn's disease recurrence. The study was conducted between November 2010 and May 2012. 104 sites were used worldwide. 297 patients were included in the study. So All study patients had undergone ileocolonic resection within 45 days before randomization, and then patients were randomly assigned one-to-one to groups given infliximab at 5 milligrams per kilogram or placebo every 8 weeks for 200 weeks. The primary endpoint of the study was clinical recurrence, and then the secondary endpoint was endoscopic recurrence. So clinical recurrence was defined as a composite outcome consisting of a CDAI score of more than 200 and a 70-point increase from baseline. And then endoscopic recurrence was defined as a Rutgers score of more than I2 or development of a new or redraining fistula or abscess before or at 76 weeks. So in terms of the findings of the study, infliximab was not superior when compared to placebo in preventing clinical recurrence. However, infliximab was superior in preventing endoscopic recurrence. When one looks at the outcomes from the study, this slide shows the clinical recurrence, and it shows that the placebo group did better than the infliximab group in terms of clinical recurrence. But just to note the p-value of 0.97, which is technically not statistically significant. When one looks at the endoscopic recurrence score, it is very clear that the infliximab group had less recurrence compared to the placebo group. And this sort of followed, the trend followed through all the different Rutgers scores for infliximab compared to the placebo group. So there are some new drugs that we are looking at the moment. There's the Reprevio trial, which had looked at vedolizumab versus placebo. The first results of the study were presented at EHCO this year. It was a multi-center randomized controlled trial in high-risk patients. The primary endpoint of the study was endoscopic recurrence, and then 77.8% of patients had a lower Rutgers score as compared to the placebo. The initial results are promising for this drug. The Americans actually advocate this drug as an alternative to anti-TNFs if patient is failing post-op recurrence. Then ustekinumab also has been researched in terms of post-op recurrence. The comparative efficacy of ustekinumab against anti-TNF agents in the prevention of post-op recurrence is still unclear. However, ustekinumab is comparative to vedolizumab in preventing post-op recurrence in high-risk patients. Larger studies are needed, but the initial results of this drug are also quite promising. Then just some novel surgical procedures which are being performed at the moment. So the one I'm going to mention is the Crohn procedure. So essentially in A over here, you have bowel resection using a linear staple cutter such that the mesenteric side is located in the center of the stump. And then in B, each bowel stump is reinforced with sutures. And then in C, both stumps are sutured together to create a supporting column to maintain the diameter and dimensions of the anastomosis. Longitudinal enterotomies are made at the antimesenteric sides of the two segments of intestine, which is here one can see by these dotted lines. And then in D, the side-to-side antimesenteric anastomosis is then performed in a transverse fashion. In E, the supporting column is located between the anastomosis and the mesentery when the anastomosis is completed. So with the Crohn procedure, there was a randomized control trial called the Supreme CD study. 79 patients were divided randomly between Crohn anastomosis and conventional anastomosis. Conventional surgery was defined as stapled ileocolic side-to-side anastomosis. The primary endpoint was endoscopic recurrence, which was defined as a Rutgers score of greater than or equal to I2 after 6 months. And then the secondary endpoints were clinical recurrence after 12 and 24 months, which was defined as a CDAI score of more than 200, and then endoscopic recurrence after 18 months and surgical recurrence after 24 months. So in this study, all patients received metronidazole if they tolerated the medication. And then medication was based on risk profile. And then enrolled patients were clinically evaluated every 3 months for 24 months, and they underwent colonoscopy at 6 and 18 months from surgery. So in terms of the results, at 6 months, the patients who had the Crohn procedure did much better than the patients with conventional therapy. And then at 18 months, interestingly again, the patients in the Crohn group still did better than the conventional group. There are other novel surgeries which aim to, one specifically being the extended mesenteric excision, which is a very promising new surgery. And then there's also studies being done on combining the Crohn as well as the extended mesenteric excision. So to put everything together in terms of a management algorithm when encountered with a patient with post-op disease, importantly, one needs to risk stratify patient. Patient can be risk stratified as a low risk or a high risk patient. Regardless of the patient being low risk or high risk, patients should receive metronidazole or nidazole for 3 months if tolerated. So in the low risk group, initially, beside the metronidazole, no specific medications, one can do a fecal calprotectin at 3 months. And if the value of the fecal calprotectin is less than 50, colonoscopy can then be done at a year. If the value of the calprotectin is more than 150, colonoscopy should be performed at 6 months. If there's no recurrence on colonoscopy, if there's no recurrence on that initial colonoscopy, colonoscopy can then be performed every 1 to 3 years. If there is recurrence, the patient can then be started on an immunomodulator or anti-TNF medication. In terms of our high-risk patient, beside them being on metronidazole, one should start them on an anti-TNF plus immunomodulator. Administration of the thiopurines increases infliximab levels, it reduces immunogenicity, and increases the efficacy of infliximab in patients with Crohn's disease. Then a lot of data does show better results in patients on the combination therapy. Then to note, even in either group, if the patient does show endoscopic recurrence, then one should escalate treatment, even if the patient is clinically asymptomatic. Miguel Reguero in this paper recommends that patients should be started on the anti-TNFs 2 to 4 weeks post-op, especially in the high-risk groups. And then the recommendation in the paper was if the patient then has recurrence at the 6-month colonoscopy, to increase the anti-TNF or to change biologics. The biologic that they recommend in the paper was vedolizumab. So in conclusion, post-op recurrence is predictable. Importantly, we do need to risk stratify our patients, and then the use of non-invasive modalities to monitor recurrence are useful complementary tests. Endoscopy remains the gold standard to diagnose and affect management of our patients, and then escalate treatment based on endoscopy regardless of clinical symptoms. Anti-TNF therapy is still the current best therapy. However, ustekinumab and vedolizumab are good alternative therapies if failing on anti-TNF therapy, and there's a lot of data which will be coming out on these drugs to come.
Okay, thanks very much. That was an excellent presentation. You want to stop sharing your screen?
I'm trying to stop sharing. Okay, stop sharing.
Okay, perfect. Yeah, so great presentation. Thank you very much. Okay, so just one question for you. The CONOS, why? Why does it work?
I think it's because you're excluding the mesentery. that's the postulations, and then also the extended mesenteric excisions. You're sort of taking the mesentery out of the area of anastomosis.
All right. Okay. Another question. In your reading up, is there specific dysbiosis, pattern of dysbiosis that's associated with post-operative recurrence?
There was, I can't remember the specific I can't remember the specific
Organisms,
names
yeah.
of the flora, the organisms, but yeah, there was.
Yes, yeah. Okay, so I'm just going to make a couple of comments. I don't see any questions on the chat, so please, guys, be interactive, ask anything. It doesn't matter. It doesn't even matter if it's not post-operative recurrence. Okay, so I just want to reiterate the point that you've made about smoking, because this is the most important modifiable risk factor that we have at our fingertips. And if you take a patient who has a short segment terminal ileal resection, you do a primary anastomosis on them, and they don't smoke, there's a very good chance that they will remain in remission for a 10-year period without any medication. So patients really need to understand this. Okay, then just in terms of the fecal calprotectin, yes, indeed, doing it about 3 to 4 months after surgery is a great idea. And if it's high, then one would certainly consider doing the colonoscopy earlier. All right, but just one point that you must be careful of is that fecal calprotectins can remain high for up to 2, almost 3 months after surgery, just because of the surgical procedure. So don't be too hasty to jump in there with a fecal calprotectin. Wait. Metronidazole, patients hate it. They often can't take it for this long. So we use it. Try at least to give 400 milligrams BD for 2 months. You can give it longer if the patient tolerates it, but in my opinion, they never do. So, but give it a shot. It's certainly worth it. Okay. And then just my thoughts on why the PREVENT study didn't actually increase the clinical or meet the clinical endpoint of clinical recurrence. Do you have any thoughts on that?
No problem.
Okay, right. So there's 2 reasons. All right. The first is that this is way too short a time to assess clinical recurrence. If the study had run over a much longer time period, you probably find it would have had a benefit on clinical recurrence. But endoscopic recurrence, of course, it did make a difference, and that's probably the endpoint that you're looking at that time period. The second thing was that people were allowed to get infliximab up to 45 days after surgery. That's way too long. Okay, they need to be started 2 weeks after surgery. Otherwise, you've missed the boat already. As you said, the histological changes start to happen within the first 24 hours after surgery. Waiting 45 days is too long. So I don't actually take it as a negative study. I take it as a positive study. I think it fully supports the use of anti-TNFs in this setting. We would go in a patient who is at higher risk, or if they won't stop smoking, to an immunomodulator, particularly azathioprine, because obviously we have limited access to anti-TNFs. And then at the next scope or the next fecal culprit, if it's elevated and they're still not under control, then one could motivate for an anti-TNF. But I think in our setting, we're forced to use immunomodulators in the high-risk patients or those patients who have obvious endoscopic recurrence at 6 months, even if they were considered low risk. Okay, was there anything else that I wanted to say? No, I think you covered everything else that I could think of. Any questions from the audience? Yeah?
Can I ask a question?
Of course you can.
So when I was preparing for the talk, the modified Rutgers score, when I did some reading on it. So I know last year in the Journal of Crohn's Colitis, they actually said that the I/A's sort of predicted not progression to severe disease, and there's various theories behind that. But then this year they came out with another paper showing that it didn't actually make a difference. What's your thoughts on that, Prof?
Yeah, I don't think it makes a difference. The reason is, so the reason they did it in the first place, because strictures at the, not strictures, ulcers at the anastomosis are very different from ulcers more proximally. Okay. Those at the anastomosis are often thought to be due to mechanical strain, ischemia, and not necessarily true recurrence of the Crohn's disease, whereas those more proximally than the anastomosis are most certainly a true recurrence of Crohn's disease. But I think it's just splitting hairs, and I actually agree with the meta-analysis that I think you can lump it all into I2.
Okay, cool.
Any questions from anybody? Mash, I saw you on. Any comments from you or any of the consultants who may be on?
Yeah, and thanks, Joe. I have a couple of comments and questions. Thanks, Aslam. I thought that was a really nice review of post-op recurrence. Regarding smoking, and this is not just in POR, you know, sometimes I get literature or I read literature that says, if you used to smoke and stopped, your risk is better than if you never stopped, if you never smoked at all.
Yes.
Is that the case, Joe, for post-op recurrence or basically Crohn's disease?
No, so it's active smoking that is the predictor. And it's also a little bit dose dependent. So the risk is much more increased in some of you smoking 20 cigarettes a day as opposed to the patient who maybe smoked on a Saturday evening when his mates come around for a pry. So, you know, very different that scenario. And we don't know what it is in cigarette smoke that actually harmful in Crohn's and protective in ulcerative colitis. And there's 2,000 different chemical components in cigarette smoke, and it's any one of those. But as I'm saying, possibly just the production of free radicals might be sufficient. Smoking changes the microbiome. You know, lots of potential reasons why it could have a deleterious effect.
Yeah. Okay. Aslam, the NOD2 mutation, they used to say he's a predictor for post-op recurrence, and then it kind of disappeared. But I think I've seen a recent systematic review that yes, indeed, it is a risk factor or a predictor for post-op recurrence. Did you come across that as well? And is that still the case, Joe? They're not two.
Yeah, I think it is still the case.
In the paper I used, that it was a paper in 2010, and they did mention the NOD2 as a predictor.
Yeah,
it certainly is, but nobody's going to be looking for NOD2 mutations, so it's kind of irrelevant.
Yeah. And then my final question is that what about the role of adalimumab? I don't know if I missed it. I think I heard you say infliximab, Vido, and obviously the thiopurines and the metronidazole. But what about the role of adalimumab for post-op recurrence? Thanks.
There's no dedicated trials. Let's answer us that, please.
No. So in the second last slide where I went to the sort of treatment algorithm, I used the American Miguel Reguero's paper, and they didn't differentiate between the two really in that paper for as an anti-TNF.
Okay.
Prof. Bottom, I don't know if you have anything.
The thoughts are that they're probably of similar efficacy, but unlike the PREVENT study, there hasn't been a formal, large, randomized control study of adalimumab, you know, like that study where it's multi-center, 297 patients or whatever. But I mean, I think we all do it in clinical practice. We take an indication for one, for example, infliximab is the only one in which there's been evidence in perianal disease, but everybody extrapolates that to adalimumab.
Yeah, I mean, I think you're right. In clinical practice, if we used infliximab and it didn't work or patients had antibodies or whatever, since we don't have everything available, we'd probably give adalimumab a try.
Definitely.
Yeah.
There's no theoretical reason why it shouldn't work as well as infliximab. The only ones where I do believe infliximab is better than adalimumab is when there's colonic involvement and when there's fistulizing disease. There, I'm still a major proponent of infliximab in that setting.
Great, thank you.
Anybody have any questions on the chat? No, we're going to make it a short and sweet one. It's not a big subject, and you did an excellent job. So there's really not much else that I can add into that at all. All right, so I'm going to close the thing. So thanks very much, Aslam. That was an excellent presentation. Thanks to EHCO University of New Mexico and EHCO India team for the support. Thanks to the Gastro Foundation and, of course, to Karen. And the recordings will be available on the Gastro Foundation website. Our next IBD session is Monday, the 13th of November, when we're going to cover conventional drugs in IBD. So have a great evening, and I will see you all in 2 weeks' time. Cheers.
Thank you.